Now that you've seen our approach to ischemic heart disease in the emergency, let's discuss this topic in a little finer detail. Let's first look at the risk factors and pathogenesis of ischemic heart disease. I know it's a little boring. Almost all of you are aware of the risk factors of ischemic heart disease. Yes, the same old modifiable and non-modifiable risk factors. Non-modifiable being things like gender, genetics, and age. Men above the age of 45 or women above the age of 55, usually in the post-menopausal age group, are at higher risk for ischemic heart disease. Women usually have higher levels of estrogen, which increases their HDL levels, which is a good cholesterol, something we'll come to later. And that is why their risk of ischemic heart disease is usually lesser. Okay? Men and postmenopausal women, that is once the estrogen levels come down, are at almost the same risk of ischemic heart disease. People with a family history of ischemic heart disease are also vulnerable. Modifiable risk factors, very important common modifiable risk factor is cigarette smoking. It increases your inflammation, it increases atherosclerosis. We'll come to that again. Sedentary lifestyle and high stress also have a pro-inflammatory effect, and that worsens atherosclerosis. All of you know diabetes, hypertension, and dyslipidemia are increased risk factors. Among dyslipidemia, increased levels of bad cholesterol, in particular LDL and lipoprotein little a, which deposits cholesterol in your subendothelial layer, and low levels of HDL, the good cholesterol that removes the lipid from your subendothelial layer. These both classify as dyslipidemia. Some people even considered high triglyceride levels to have an increased risk of ischemic heart disease. However, LDL, lipoprotein little a, high levels, very bad prognosis. HDL, low, poor prognosis. Along with this, obesity, that is a BMI of more than, we'll see what the cutoffs are, or waist-hip ratios. I've actually put up the BMI cutoffs for Asian population in the show notes. Please go through that. Waist-hip ratio would be a much better measure of ischemic heart disease risk, because when you have a high waist circumference, it means you have a lot of fat around the abdomen, very classically seen in Indian and Chinese population. In Indian and Chinese population, we also deposit a lot of this fat around our viscera or around our organs like the pancreas, the liver. This is called visceral obesity. One of the best measures of visceral obesity is waist-hip ratio. When you have obesity with dyslipidemia, hypertension, and diabetes together, you call it metabolic syndrome. We will touch this again. Obstructive sleep apnea is, so this is metabolic syndrome, right? When you have centripetal obesity, the Indian Diabetic Federation says that waist circumference of more than 90 centimeters in male or 80 centimeters in female is considered obesity. Hypertriglyceridemia more than 150, low HDL levels, okay, more in females as you can see. Hypertension or hyperglycemia, that is diabetes. If you have more than 3 out of these 5, 3 or more out of these 5 parameters, you are classified as having metabolic syndrome. What's the importance of this classification? If a patient comes to you with any one of these conditions, that is diabetes or hypertension or dyslipidemia or obesity, look for the others. A patient who has metabolic syndrome has a much higher risk than having any individual feature, right? So, metabolic syndrome is a sum total of all these risk factors. Now, all of you know that these are modifiable risk factors: cigarette smoking, sedentary life. What you would be a little surprised for knowing is that there is a condition called obstructive sleep apnea, which is usually associated with metabolic syndrome, that also increases the risk of ischemic heart disease. Even more surprising is that chronic inflammation, any disease with chronic inflammation, for example, rheumatoid arthritis, HIV, chronic HIV, all of this also increases the risk of atherosclerosis. Simply put, inflammation, whether it be due to chronic conditions or cigarette smoking or high stress conditions, also increases atherosclerosis. If you ask how is inflammation related to atherosclerosis, I would take you to understand the pathogenesis of atherosclerosis. Okay, before we go to the pathogenesis, I would want to quickly discuss what are the clinical markers that we use for cardiac risk. In some situations, a patient might come to you and ask, Doctor, I think I have had multiple heart attacks in my family. Can you estimate my risk of having a heart attack? So when do I tell that he is high risk or low risk? One of the ways to do that is doing the usual tests. You can do the levels of cholesterol, high levels of LDL, high levels of lipoprotein, little a, high levels of total cholesterol. All of this usually suggests high risk. Low levels of HDL also is high risk. So one of the ways you can combine both of these things, total cholesterol or LDL divided by HDL. Total cholesterol divided by HDL is also called non-HDL cholesterol. This is considered the best test for dyslipidemia and to quantify cardiac risk. So if a patient comes to you and just gives you the cholesterol profile or the lipid profile, the best way is calculate non-HDL cholesterol. High levels of non-HDL cholesterol should make you think, yes, this person has high risk of heart disease. Now I said it's not just cholesterol, but it's also inflammation. We can use markers of inflammation. I'll come to these. We can use markers of inflammation like hsCRP, homocysteine and fibrinogen. However, the best marker would be a combination of inflammation and dyslipidemia. So the best marker for measuring cardiac risk in the lab is to combine inflammation and dyslipidemia. hsCRP plus non-HDL cholesterol. Okay, so if you're asked this question, which is the best biochemical parameter? The one in red is it. Okay. You can also use direct measures of atherosclerosis by looking the blood pressure between your lower limb versus upper limb blood pressure. Usually the lower limb blood pressure is higher than your upper limb blood pressure. That is, ankle pressure is higher than the brachial pressure. Or your ankle blood pressure divided by your brachial blood pressure should be greater than 1. If you have a lot of atherosclerosis, particularly in your iliac artery, one of the common sites, your ankle blood pressure will be lower. Anybody with high atherosclerosis will have an ankle brachial index of less than 0.9. So this is an indirect hint of looking for atherosclerosis. Nowadays, there are CT scans which can actually look inside the calcification of your coronaries, atherosclerosis and calcification of your coronaries. We will come to this when we are discussing chronic stable angina. Now, I would want you to take you to the pathogenesis of ischemic heart disease. At the heart of the pathogenesis of ischemic heart disease would be atherosclerosis. I'm sure all of you know what atherosclerosis is. When the cholesterol that is in the blood starts depositing in the subendothelial layer, that is where we say there is the beginning of atherosclerosis. However, the key event in atherosclerosis is not just deposition of cholesterol, but when macrophages engulf your lipid droplets and become what are called foamy macrophages. Foamy macrophages are very, very important because foamy macrophages constantly release cytokines producing inflammation. Inflammation and deposition of lipid will lead to swelling of the subendothelial layer, and you will have this kind of a lipid core which is all swollen. As the lipid core rises, it breaks the endothelium in multiple areas, and this endothelium is sealed by fibrin because there is a lot of fibrosis happening due to the inflammation. So ultimately, an atherosclerotic plaque, which is the pathognomonic lesion of coronary artery disease, will consist of a lipid core, a fibrous cap, and foamy macrophages. Right? This would lead to what we call a demand-supply mismatch. What does that mean? If you can look at the lumen of a coronary artery with atherosclerosis, you can see that the blood flow, the lumen is limited. So, especially when you require high blood flow through the coronary, that is when you are exerting, when you are climbing stairs or when you are walking uphill or when you are picking up a heavy box, when you are exerting, it is at that point that your heart requires greater than normal amount of blood and your coronary cannot dilate to accommodate that blood. So your blood supply to the heart muscles goes down. The muscles become ischemic. Ischemia leads to release of substance P and potassium, which irritates the C type of nerve fibers that innervate your heart, and that produces the dull chest pain which we usually call angina. So this is a demand-supply mismatch, right? These are your coronary vessels. So you can see that you have a right coronary and you have a left coronary. The left coronary divides into the left main coronary artery and the left anterior descending, and the left main coronary artery, which then divides into the left anterior descending and the left circumflex. This is a revision of the basic anatomy. You also have the right coronary, which swings and goes to the inferior part of the heart. These are your epicardial coronary vessels, right? Okay, and in case of having an atherosclerotic plaque, you have what is chronically called a demand-supply mismatch. So in such patients, whenever they exert, they develop chest pain. Whenever they sit down, the demand goes down and the supply becomes adequate, the chest pain disappears. This kind of chest pain that appears every time you exert and disappears every time you rest is what we call chronic stable angina. Classically, chronic stable angina has three important parameters. So, when we say chronic stable angina, it has to involve the nature of the pain, aggravating and relieving factors, and duration. Why is this important? Any patient who is coming to you with these three classical parameters, you would say that yes, this is classical chronic stable angina. Suppose the patient has only two of this and not all three, I would say, oh, this is not very typical of angina. This is a little atypical kind of a pain. If there is only one of these features, then I would say, oh, this is not angina. This is something else. You will see the importance of this when we evaluate chronic stable angina. So let's look at this one by one. The nature of the pain, the aggravating and relieving factors, and finally the duration of pain. The nature of pain. Chronic stable angina, because there is ischemia, the ischemia is usually because of inadequate blood supply, which leads to accumulation of substance P and potassium, and that irritates, as I said, the C type of slow pain fibers. Slow pain fibers, you cannot really localize the pain. The patient says it's somewhere behind my sternum, retrosternum, and when asked, the patient usually says it is a crushing or squeezing, deep-seated pain. In fact, the patient might actually do this, right? The patient might actually do this. Say, I feel a crushing pain. And this sign that the patient doing this is what we call Levine sign. Levine sign, right? So the presence of Levine sign, a crushing, squeezing type of retrosternal chest pain, is one of the classical features of chronic stable angina. Because of the shared nerve supply, this pain can radiate to the left arm, it can radiate to the jaw, it can radiate to the epigastrium or even the back. Where it does not radiate to is also important. Remember, it does not radiate above the occiput, below the umbilicus. It does not usually radiate to the right side. And it does not radiate to the area of the trapezius muscle. Very important, because it is usually another condition, that is pericarditis, where you have radiation to this area. So the classic nature of pain, the crushing type of pain, retrosternal, dull aching usually, Levine sign is present, radiates to certain areas, does not radiate to certain areas, and very interestingly, the pain is so severe that it is usually associated with what is called diaphoresis. Diaphoresis is sweating, tachycardia, palpitation, which usually shows that there is a lot of epinephrine, norepinephrine, sympathetic overdrive, seen in very severe painful conditions, and angina is one. So this is the nature of chronic stable angina, right? So if this kind of pain somebody has, you would say, oh, this is one factor in chronic stable angina. What are the other factors? The other factors are the aggravating and relieving factors. It is a demand-supply mismatch. So if you increase the demand, that is by either stress or exertion, that will increase the angina. If you reduce, or if you either increase the supply or you decrease the demand, that is either by resting or by taking vasodilators like nitrates, that should decrease the pain. Because the pain is reduced by resting, anytime the patient develops a chest pain, he rests. And because he rests, the pain usually lasts only 3 to 10 minutes, mostly 5 minutes around, never more than 15 minutes. So please remember, Chronic stable angina occurs due to atherosclerosis. We have discussed the risk factors and the pathogenesis. Atherosclerosis means having a lipid core, a fibrous cap, and having a foamy macrophage or many foamy macrophages within the plaque. Atherosclerotic plaques produce a demand-supply mismatch, and that produces the classic type of chronic stable angina. Right? How this chronic stable angina leads to the further complications, we will see subsequently.